Elizabeth, I'll just confirm that you can see our slides here.
I can, but I can't see your webcam yet.
Okay.
Really?
That might be on my end, though. Let's see.
Hello, testing.
Elizabeth, we can see it, so it might be your end.
Okay,
Okay,
great.
thanks
So
very much, Patty. Did you want to say anything, Patty, before we get started?
That's right, it's too late. Go ahead.
Okay.
That's very ominous. Okay. So Elizabeth did a great introduction for myself and for Nell here. I'd also want to acknowledge that Dr. Brenda Berkeleyan was a big part of this presentation as well. And it's not us just creating this information. There's a lot of people behind the scenes that have really helped out, and we're just sort of digesting it and presenting along to you today. Nell will generally be speaking to the trends and regulations surrounding driving across Canada. Then I'll speak to the best practice and evidence, and we'll both sort of try and work into how to apply the recommendations to real world practice. And throughout the presentation, we'll try and give you some practical tips throughout. So we've changed the order of the learning objectives just a little bit to start with the provincial regulations, and then to move into describing the best practices related to return to driving through the best practice recommendation guidelines and the managing the transitions of stroke care modules. I'd like to start with a case, and as we work through this together, I want you to think of your own Jones and your own practice context. So maybe you're in acute care or outpatient setting or in the community or in a clinic. Just consider your own practice setting, but we'll try and use the case of Joan here to run through some of our examples. So Joan's an active and independent 81-year-old. She organizes her senior Scrabble club, and she was admitted with stroke. Her goal is, when can I drive again? I also like to start with this picture to frame our discussion. Joan checks in with us at each. Joan checks in with each of us along the way, but her journey doesn't end or stop with any one of us. So when we speak to her resumption of life roles and activities in the context of driving, it's not just about driving yes or no with Joan. We're trying to answer the bigger question of how will Joan get around in her community after her stroke? And what can we do as clinicians to help her prepare to be successful in this regard?
It's all about community integration.
And with that, I'll pass along to Nell.
So I'm starting out with the not so exciting topic of regulatory trends across Canada, but yeah, it's an important area to address so that we all understand the context within which we are working. As well, I'm going to discuss some of the emerging trends that seem to be happening quite recently in Canada. So as we all know, laws that govern driving and the rules of road in Canada are determined at the provincial level. So today, I'm actually going to give a brief overview of the differences in medical reporting of drivers by province and some emerging trends that we are seeing that affect OTs and other healthcare professionals in Canada. And first, a quick disclaimer to say that I may refer to the MTO or the DMV. Those are both titles for provincial licensing body, okay? And every province has their own titles. How do I forward? There we go, okay. So starting with a quick summary, there are two types of reporting in Canada. There's discretionary reporting and mandatory reporting. British Columbia, Alberta, Quebec City, and Nova Scotia all are identified as have identified physicians as discretionary reporters. But in BC and Quebec City, there's a qualification there that says that if a patient continues to drive against medical advice, it then becomes mandatory for the physician to report that driver to the licensing facility, licensing organization, licensing body. And when it comes to mandatory reporting, Saskatchewan, Manitoba, Ontario, New Brunswick, and Newfoundland all have mandatory reporting requirements within these provinces. For physicians. And I'll also point out that Saskatchewan, as of about 5 years ago, made it mandatory reporting for occupational therapists as well. So that is one of the possible emerging trends we may be seeing. But the fact that the provincial licensing bodies are focusing more on function and see the role of OT in assessing function and determining if somebody has a functional ability to drive. In Ontario, there's major changes coming July 1st as well, 2018, and I'm going to be speaking about that in the next couple slides. First, I want to mention that in British Columbia on, let's see what date, It just changed in March 1st, 2018. There was some significant changes to the assessment or the testing of medically impaired drivers. To explain the system, there's 3 different streams that drivers in British Columbia might go through regarding their driver's license. The first is the regular licensing process. It's conducted by the ICBC, which is their licensing authority. And all people who want to get their driver's license go through the ICBC road testing. Sorry, that's the last point on the slide. I have it reversed in my notes. As well, if somebody has a significant or severe disability, or medical condition, they will be asked to do a comprehensive or functional driver evaluation. And that's done by people like myself, somebody who does 2.5-hour driving assessments in clinic on road with a driving instructor. So those are the people that need adaptive equipment or that might have more profound impairment. The third stream is the group that will be asked to go through an enhanced road assessment. This is the stream that has been most affected by the changes March 1st. That used to be in British Columbia that the Drive Able assessment was the tool that was used. However, that has been changed. As of March 1st, drivers in BC are no longer required to do the Drive Able assessment. If they have mild cognitive impairment, general aging or frailty issues, that sort of thing, just some mild possible impairment, they will be asked to do an enhanced road assessment, which is conducted by the ICBC. So that is the licensing authority in British Columbia. As for Ontario, since 1960, we've had mandatory reporting for physicians and optometrists for anybody who may have a condition that affects their driving ability. Anybody who has a condition that may affect their driving ability was to be reported by physicians and optometrists. But as of July 1st, those regulations will be changing. They've announced the changes. Now, the new regulations identify doctors, nurse practitioners, and optometrists, sorry, I'm going to go back a slide, as having mandatory reporting for specific medical conditions. So there's mandatory reporting only for specific mandatory conditions, which are basically cognitive impairment that results in substantial limitation in ADLs. You can see the role of OT in assessing that. Sudden incapacitation, such as seizures. Motor or sensory impairment, severe impairment. Now, who assesses motor and sensory impairment? Often occupational therapists do. And as well, of course, vision impairments, if they don't meet the ministry standards. I have them laid out there. That is the standards in Ontario, but also the guidelines that are recommended across the country. Substance use disorder is also identified, and specifically it actually says that, excluding alcohol and excluding cigarettes and caffeine. That's what it is. So if substance use disorder is identified as a mandatory reporting condition. And finally, on a bit more serious a note, mental illness has been identified in certain situations as being a mandatory reporting condition. Specifically, it says if there's acute psychosis, suicidality, or intent to use a vehicle for suicide or for harm of others. Naturally, this ties into what has happened just on Monday in Toronto, where somebody did use a vehicle to harm others. And that is a situation where that would have been mandatory for physicians and nurse practitioners to report. Quickly as well in Ontario, one last slide, just saying that now occupational therapists are identified as discretionary reporters. I'm not sure if I mentioned earlier, I was supposed to. Yes, I did. Saskatchewan has mandatory reporting for OTs, whereas in Ontario, we are now going to have discretionary reporting for OTs. There's going to be a lot more information forthcoming from the college about that. So if you're in Ontario, keep your ears to the ground. The college and OSOT will be making announcements in the near future about educational opportunities regarding that discretionary reporting for OTs. Now, I'm going to touch quickly on the process, and this is in Ontario, Ministry of Transportation Medical Review process. I'm pretty sure it applies in general to other jurisdictions, but important notes to make is that when a person has a medical condition and a physician or nurse practitioner or OT makes a report to the ministry, the doctor or the OT are not taking the person's license away. We are reporting it to the licensing facility. The licensing body then makes decisions about that person's license. They will choose if they need more information. They will choose if they're going to suspend. It's up to them. The OT or the doctor, in fact, is not the one that takes the license away. Just a quick glance at what the form looks like in Ontario when you're going to be asked for license suspension and ask for more information. And this is one of the examples of Ministry of Transportation forms that physicians will be asked to fill out. We will have a similar form for OTs to fill out come July 1st. Sorry.
And
I think I
turn
passed
it over to me. Hello.
to Mike.
So we'll speak now to the best practice recommendations for driving after stroke. And I'll give you a quick summary of my interpretation of them. Generally, after a stroke, a person is asked to stop driving for at least 1 month after stroke. That doesn't mean that they can resume driving after that month, which is a common misconception. I've been told to stop driving for a month, now I can start again. What it means is after that month, a person should be screened for any residual deficits, sensory, motor, or cognitive. And if anything would suggest that a stroke has affected a person's ability to drive, then a full comprehensive driving evaluation is recommended. As well, if there is any deficits that are noted, then a referral to a training program to help a person prepare for a road test or resumption of driving is recommended. So we'll break these down into the individual pieces of evidence. And essentially then after retraining, then there's a process of screening again, and hopefully or ideally relicensing. So in terms of the stop driving, the evidence suggests that a person should stop driving for at least 1 month. And there's also a note on if a person has 1 or more transient ischemic attacks, they should also not resume driving until a comprehensive assessment shows no loss of functional ability and discloses no risk of reoccurrence. As well as that any underlying cause has been addressed with any sort of appropriate treatment. So atrial fibrillation or any potential cause of those TIAs is addressed. After 1 month, patients or persons who are interested in returning to driving should be screened. Screening, they do mention in best practices, ideally by an OT, and generally should include sensory, motor, and cognitive assessment. We will absolutely dive deeper into what screening should look like according to the evidence, but I wanted to take a moment to speak to the language around screening. What screening means is not answering the question. So if we go back to Joan, it's not about answering the question, can Joan drive? That's probably the most common question we're asked by our clients and in our referrals, but it's not something we can answer with the off-road tools we have available. Generally, how I frame my role in this case is to answer the question, has Joan's stroke potentially affected her ability to drive? And that is something I'm far more comfortable speaking or answering with the screening tools that I have available. The distinction I think is important because it changes the expectations as well as the professional insecurities that we might have around answering those questions. That does bring us to the next point in best practice, which is for anyone who does potentially have residual neurological deficits that might impair their driving ability, a full comprehensive driving evaluation is recommended. That also brings us back to my role. So I wouldn't be conducting the comprehensive driving evaluation, that'd be someone like Nell, but I can answer the question, is Joan ready for on-road testing? And if so, that brings us to the last point, what can I do to help someone like Joan prepare for an on-road test? So what can I do in the meantime to help her prepare? And that speaks to the last bit of evidence around referral to training programs. Now they do speak to simulator-based training as having the most evidence around it, and we'll certainly speak to some of the off-road training tools that we have available. In the context of how this fits with reporting guidelines, essentially it's a process of screening, potentially retraining, and then some sort of review through the medical process, as Nell already spoke to. What this brings us to is the reason why most of us are on this call today is, what does this look like in practice for me? So we know what we're supposed to be doing in terms of the best practice guidelines, but what does this mean for me? So as part of my research, we did a survey of clinicians to see what was going on in real world practice. And the questions that came up around addressing driving is, what is my role? What do I do about this? Are the assessments that I'm using appropriate? And I know they have problems on this particular assessment or that assessment. How do I turn that into treatment to help someone like Joan? So the next part that I wanted to speak to is what is our role in addressing driving as part of stroke care? So for us, we address driving as part of our overall stroke care. One of the most, actually very recent, the evidence-based review of stroke rehabilitation, which was just updated in the last week, gives an overview of the best practice guidelines. So if there is concern about a person's ability to drive, that needs to be identified and proper assessment and treatment initiated. And what they suggest is a two-step process where a person is first screened for readiness to participate in on-road evaluation and then provided some sort of contextual therapy to help them prepare for it. So in differentiating our role, the majority of us are here to answer, has a person's stroke potentially affected their ability to drive? If so, are they ready for on-road evaluation? And again, is there anything I can do to help them prepare? It's much easier to answer that question than to try and gauge can this person drive or not, which is often the pressure that we're put under. So how we fit, or when we speak to our role in addressing driving as part of our overall stroke care, we're considered generalists. Addressing driving is broken up into 3 tiers of expertise, and we fit in that first tier. And that first tier includes screening, but doesn't stop at screening. It also includes a health promotion component or an educational component that we'll speak to as well. I should also mention that the other tiers of expertise then speak to someone like Nell, who would perform the on-road assessment or the in-vehicle training or adaptive devices, which is not something that we necessarily get into in our day-to-day clinical practice. So in terms of screening, we're attempting to address the client's goal of driving and answer those questions. Has their stroke potentially affected their ability to drive, and are they ready for on-road evaluation? We can provide referrals to someone like Nellemarie or to any of the resources in the community. And then the third piece that I spoke to is health promotion. Let me turn to my notes here. So addressing driving does not stop at screening. We have a duty to address how a person can also be mobile in their community after stroke, because the chances are, and the research shows, that they may not resume driving. The estimates put it around 30 to 40% of individuals after stroke are actually successful in returning to driving. So our role also includes mobility planning, which means making a plan for how a person can resume their life roles and activities without driving. We'll certainly speak to strategies about how to address that as well, but that certainly fits into our day-to-day practice as well. So it's not necessarily making a determination of whether a person can drive or not, it's planning for them not driving and seeing if they're ready to move on to the next stages of best practice. I'll turn things over to Nell to speak to some tools that we can do to address these roles and recommendations.
So I think that one of the trickiest parts about speaking with clients about driving is that we sometimes have a feeling or our concerns and we can't articulate them. And if we can't articulate them, we can't rationalize them, and then we're not sure what to do and how to proceed. So I'm going to be speaking a little bit about that with reference to what's in your toolbox or your toolkit. Basically, sometimes you've got, like I said, you mentioned this gut feeling. What we like to propose is that you use a systematic approach to being able to go through what are all of the risk factors? What are all of the things that could inform my decision as to how to proceed? Remember, it's not a decision about driving or not driving. It's a decision about how you're going to help this person proceed through this journey of being as a driver. Okay, so with a systematic approach, it allows you to inform your gut as to what exactly it is that makes up your decision, be able to articulate that decision, and that allows you to rationalize and explain it to the health team and the client, as well as allows you to document your decision. The best way to go about this, there's a few mnemonics out there. CanDrive has a great mnemonic. CanDrive is a large research study across Canada. I'm not going to get into the details, but they produced a mnemonic that allows you to address all the different risk factors that you need to consider when you're screening somebody for driving. Things like cognition, is it an acute or fluctuating illness? How many medical conditions do they have? How many medications do they have? Because 1 plus 1 plus 1 equals more than 3 when it comes to medications and medical conditions. What is their driving history? It is relevant. If somebody is a truck driver and has driven well over 1 million kilometers in their life, then they are going to have that as an overlearned skill, and that's going to carry them further. What is family report? What is their vision like? Obviously very important to screen that. And finally, to take a look at whether or not there's drug use or abuse, and that includes alcohol, cannabis, and perhaps over-the-counter medications or prescription medications. So,
this is me. I'm going to jump.
Yeah, you're going to jump in here. Yeah.
I just want to jump in quickly here to say that it's not just OTs that own driving. Certainly at the level of screening and planning, how a person accesses their medications, their food, their exercise, their spiritual activities, that matters to everyone. Clinically, I'm often speaking to nurses to see how a person is managing on a unit, especially in the evening or after hours when I'm not there. And in terms of social work, how a person copes with changes around the loss of their roles and their identities associated with driving. So I do want to say that this applies, addressing driving after stroke applies to absolutely everyone. It's not just owned by physicians or occupational therapists or certain professions.
Okay. And who's on this? Is this you again? Yes.
Yeah. So a big part of the initial interview around addressing driving is starting the conversation. So how do you start the conversation? Generally, I come in and I'm often open and upfront about what the conversation is about. It's all about informed consent when we speak to driving, and explaining my role and my obligations around that. But a big part of it is to determine, or I explain that I'm here to try and understand if your stroke has affected your ability to drive. And that's generally how I frame my role. As well, in the meantime, we'll try and figure out what do you do with your driving and how do you get there now? And in the meantime, let's make a plan for how you can get around while you're not driving. And that's prior to discharge from acute care, that's in the community, and that's in outpatient therapy. That conversation should be happening absolutely everywhere.
Okay. So I'm going to talk a little bit about a mobility plan. Often after I've seen clients, if they aren't able to drive anymore, as in my situation, but in many of your situations, it'll be somebody who's not being considered for driving at this point in time for whatever reason, whether it's not ready yet, not that sort of thing. So this comes out of research that has been done by Dr. Nagley and Dr. Rappaport. Give a mention to that. So I'm referencing that here. Their work has shown that it's important to make a concrete plan with the client, and we are well positioned to do that. So, working with the client, asking, make a list. What are all the different things that you used to drive to? Did you used to drive to church, out for dinner with friends, to the doctor's offices, visit grandchildren, all of the things, the bank, groceries, whatever it is. Make a long list of all of those things that you want to drive to and have been driving to, and then brainstorm a list of all the different ways you could potentially get to those places. And really, truly, a comprehensive brainstorming is important here. And this, I should have said, it's important to do this with the client, and if there's family around that helps support the client, important to have them there for this process as well. Once you've brainstormed through and have a good, a list of all the different options that are available, to actually put into place a mobility plan. This is an actual schedule that shows where the person needs to go, when, and how they're going to get there. The reason that it's important to have this plan and to share this with the people that are named in the plan and the client is because, people clients love, lovely clients. It's so wonderful. They are fiercely independent. And, that makes what we do very satisfying, in fact, because that's what we want to help them achieve, is to be independent. But when they are that fiercely independent, they don't want to ask for help. And when people don't want to ask for help, they just don't pick up the phone. So if you don't have a plan in place, people aren't going to pick up the phone for help. If they don't pick up the phone to call their daughter or their son or whoever it is and volunteer for help, then they're just not going to go out. And if they don't go out, their health will deteriorate. And so very important to have this sort of a plan in place that allows individuals to transition to being able to get into the community without driving.
That's right. So those two tables that Nell mentioned there are things that I use commonly in my practice. So that's something that can take a session to do. It doesn't need to take long to make a plan, but it's incredibly impactful, particularly when someone is before someone transitions back to the community and doesn't have those things in place. So doing that in ideally an acute setting or an inpatient rehab setting before a person transitions home and needs to access those things but does not have the tools to do so. The next question then is, how do you find out what's available in your community when you're making these plans? I provided a link here, and I'll mention this as well, that any of the links that we speak to in the presentation, I've collected them on one of the slides later, so you don't have to frantically try and scribble them down as we go through. But generally, the Heart and Stroke provides a list of some of the professional services that are available region by region and city by city. A big thing to note is that what's available is extremely context dependent. So whether you're urban or rural, you'll have absolutely different things available. It's important to know what is available in your community. And I know that takes time to try and figure out. It's a great project for students, for any volunteers, things like that, to just do a nice search on Google and figure this out. The kinds of things that are available can be professional. Remember, so in terms of professional services like accessible transit, bus routes, drug and grocery delivery services. But remember that a lot of professional accessible transit generally is aimed towards getting towards medical appointments. So that doesn't always address some of the leisure or social activities. So that comes in terms of non-professional things like friends, family, neighbors, church groups, or local services. The big point here is to make a plan, anything prior to discharge, prior to someone being in the community and being stuck.
Yeah. Sorry. Is there a slide? Yeah, there it is. Okay. So again, we're going to return to the toolkit here and speak a little bit about the interview. A study done by Dickerson and Bedard in 2014 indicated about different components that you need to think about whether or not their medical concerns could be affecting their driving ability. The three things as itemized here, insight and awareness, planning and execution, and emotional regulation, executive function, essentially, right? With insight, it's interesting, obviously if somebody is to compensate for an impairment, it's important that they're aware that it is there. Otherwise, if they aren't aware that they get fatigued and they're going to go out and drive fatigued, they could be driving impaired. However, on the flip side of that, recent research out of the CanDrive studies has shown that there's a correlation between the ability to decrease perception of your own abilities and increased crash risk and being over 80 and under 5,000 kilometers driven. So it's interesting because there's a little bit of a flip side to that. Generally, insight is always a great thing, but you listen to the person and as well, if they're feeling that there's limitations apply, that very well could be the case. When it comes to planning and execution and IADLs and ADLs, it's important to mention that with instrumental activities of daily living, that is one of the key red flags. If somebody's losing their ability to do their banking independently, to plan their own appointments and make it to them on time, if it's a change, then that is when the concern for driving should start to happen because it's early on. And so when these abilities are affected by stroke, it is a sign and a red flag that their ability to drive may be affected. Once somebody is not able to conduct their own ADLs for cognitive reasons, that is a big red flag that driving is affected, and that needs to be looked at closer. That's enough for that slide, I think. So I'm really not, accustomed to this webinar thing, but I think we're doing okay, are we? You guys can fill out the questionnaire at the end. We'll flip it back to you.
All right, so then the next question is, in terms of screening tools, what do I use? Again, in the evidence-based review of stroke rehabilitation that it was just updated and in the last few weeks, there is still no specific assessment tools which can accurately predict who is able to drive and who cannot. My main caution here is in using any one test to determine medical fitness to drive. So singularly doing a MOCA or a single screening tool or assessment is not enough to get a picture if someone can drive or not. There is, however, a resource provided by the Stroke Best Practice website that does list some of the common assessment tools, and I provided that link there. It speaks to what domain that tool looks into and gives, where available, if there's a cutoff score or some sense of what the correlation is to driving. It also provides the references if you want to look back at the primary literature. The big question then is, if there's no specific tool to use, what's actually happening in clinical practice? And this is again, comes from our survey. The most common tools that are used are the MVPT, the Motor Free Visual Perceptual Test, the Trail Making Test A and B, the Montreal Cognitive Assessment, some physical assessment of range of motion and or reaction time, and then the Useful Field of View test.
What which version of MPPT?
In our when we asked or surveyed people, it was the original version.
Interesting. Okay.
Yeah, and that's a common question that comes up as well, because a lot of the research is towards the original version.
Yeah, that's fair.
There's some limitations there.
Moving on.
So I don't want to linger too much on individual tools, so I'll just touch on quickly two of the most common ones that come up. One of them is the trail making test, and that does have some of the better evidence associated with it in terms of how much evidence is available. Generally speaking, how I frame this activity when I do it with clients is there is a disconnect here between this activity and driving. At least it feels like it and it looks like it to the client. So when someone does this activity, they're instructed to connect the dots in order, in increasing order, alternating between numbers and letters. So you can see an example I put on the slide there. More errors or longer time is more predictive of failing a road test. How I frame this with clients when I'm sitting down with them and have them in front of me is that I recognize there's a disconnect between what this looks like in driving, but I do this activity because research shows it's a good measure of your ability to take a lot of messy visual information and quickly make sense of it, which is an extremely important skill of driving.
You know what I also as well, I say you have to pay attention to more than one thing back and forth, and it's kind of like making a left turn. Are you looking at the green light? Is the traffic still clear? Or is it cleared yet? Is there a pedestrian crossing? So you're having to alternate your attention between more than one thing.
Exactly. So a lot of people will challenge you on, why am I doing this pencil and paper activity, to get a sense, and that's often a way that I'll address it. Similarly with the motor free visual perceptual test, again, it looks at different domains of perception. So for example, in this one, this might be a snapshot through to represent a windshield, looking through and extracting something important from many other things around it. So knowing that there's a kid playing on the side of the road, or seeing that there's a stop sign from a very messy visual, a lot of visual information.
Just to forecast that all SOTs who do this regularly have it memorized, so we will ace it. Ace it when you try it on us.
Exactly.
Sorry to throw it.
No problem. Generally speaking, there was a lot of cutoff evidence available that has been updated or changed to generally show that more errors and more time is more likely to fail a non-road test. Again, there's no hard cutoffs at this time.
I just wanted to speak to visual screening tools. It's important to say screening as opposed to assessment. Assessment of vision is left to vision specialists like optometrists and ophthalmologists. OTs do screening, and other healthcare professionals could screen as well. The standards recommended across the country are basically 120 degrees of continuous vision. This is field of view, your visual field, and 15 degrees above, 15 degrees below that horizontal line. That's the visual field requirement. Then 20/50 visual acuity with both eyes open. It's important to always say with both eyes open, because with driving, you are generally driving with both eyes open. Things to take a look at, oculomotor control. Is there strabismus? Is there nystagmus? Always think about, stroke is one diagnosis, but what else do they have? Is there diabetes? And if there's diabetes, that could be affecting their vision, could be affecting sensation in their feet. So you need to think about all of these things, and particularly when you're screening their vision for driving. Most importantly, if you do see any deficits or anything that you think doesn't look right, that you need to refer on for proper assessment.
That picture that you were looking at, if we go back,
Sorry, go ahead.
is a quick example of someone with a loss of visual field. So they would be responding to lights, and this would be a map showing that they've missed a certain part of the visual field.
Basically, a light, they look through a visor and a light shines. Every time the light flashes, you have to push a button. If the light flashes and they push the button, you get a little tiny white circle, whereas if the light shines and you don't push a button, you get the black dot where the X's are. So that's showing where they didn't see the flashing light. As
a clinician, I'll often ask clients, if they go for this kind of testing, to bring me the results so I can see them as well. It's always very useful to know. That's okay. The physical screen, and this is you.
Okay, physical screen. You know what? Generally, you know, we're functional. We're OTs. We do functional focused screening. And when you're thinking about whether or not somebody can drive, if I'm assessing somebody with what I think is mostly cognitive impairment, I will do just a very quick range of motion and strength. If they're able to walk around, there's not, you know, dragging a foot or anything. That's, you know, it's pretty good for driving. You need to take a look at their coordination and sensation, if there's any reason for them to potentially have decreased sensation. And specifically, I look at pressure sense on the bottom of their foot, and we would look at proprioception. It's a very gross test. It's not very, and I don't mean because you touch their feet, because I don't mind that, but it's just not, it's not very sensitive, but it's something. We do a little bit more specific testing in the vehicle to see if they're able to put, you know, where their foot is, but just something to think of, that the screening has to be functional. And what is their ability to get in and out of the vehicle? That's not part necessarily of what I'm assessing when I do a driving assessment, but it is something that the therapist should be considering if the person's going to be returning to driving, as well as, of course, loading and unloading their gate aid.
Those 2 points are things that I commonly look at in my practice. Can they get into a vehicle? Because that can be a barrier to driving. Maybe they have the skills or the ability to drive, but can't get in the first place. And particularly if they've been given a new gate aid, if they're alone, how do they get a walker in and out of their trunk? How do they load up a wheelchair for the first time, or a prosthesis, or things like that?
And for entry and exit, it's different getting into one side of the vehicle than the other. So they might be accustomed to getting in the passenger side, but not be able to get into the driver's side.
So again, those are considerations before you send someone back to the community to make sure that they can even get in the vehicle, or as a passenger in the vehicle in the first place.
Quick summary of a comprehensive driving evaluation. Generally, it's about a 2.5 to 3 hour assessment by an occupational therapist that consists of an hour and a half in the clinic and a 40-minute road test with the OT in the vehicle and a driving instructor in the front passenger side with a break on their side. There's really no circumstances under which an OT should be getting into a vehicle, or other healthcare professional for that matter, should be getting into a vehicle without a driving instructor. It puts you at risk, puts the client at risk, and puts the public at risk, just to be clear about that. Passionate about that. I'm sure you picked that up. So this is basically what I cover in a comprehensive driving evaluation. I don't need to go into depth about it. In Ontario, the cost is quite high. It ranges from $500 to $800. It does vary across the country because there are some provinces where there is partial funding, certainly for the occupational therapy portion of the assessment. In addition to doing a driving assessment, we can look at entry into the vehicle and that sort of thing as well. That can be addressed if it is requested. We will consider the outcomes. Do I do outcomes in here? Sorry, let me flip ahead. I don't think so. So generally in a comprehensive driving evaluation, you're looking at whether or not the person is able to just go straight back to driving, whether or not they need to not drive at this time, if it needs to be revisited down the road or not, and whether or not the person needs driver training with a rehab facility, whether it's with equipment or just to get back to driving without equipment, with a driving instructor and supervised by an occupational therapist to see if they're able to get back to driving. Okay. So I think now we're going to be going into off-road activities. Yeah.
So we'll round the bend here in terms of what can I do to prepare someone for, what can I do off the road to prepare someone for resuming driving or prepare them for a road test? Generally speaking, in terms of the research evidence, there's 2 main approaches to off-road intervention for driving. A bottom-up or a component-based approach which targets a particular skill. So this would be your tabletop activities that look at things like visual processing. The other bit of research evidence shows is a top-down or task-based approach which uses contextual treatment, so behind-the-wheel activities like a driving simulator or actually driving on the road. In terms of what the research evidence says about both these approaches is there's no clear evidence for any sort of improved on-road performance, nor which skills should be targeted for a bottom-up approach, and there's still very limited evidence for even a task-based approach. There is some evidence or limited evidence to show that simulators may improve visual cognitive skills related to driving, but no clear evidence into whether that translates to actual on-road performance. So if we know that there's very limited evidence based on the activities that are available, what's actually happening in practice? So what can we do in our day-to-day practice? So in our survey, generally everyone we surveyed, and this was a small sample, used some form of technology for driving. It's one of the more obvious ways to get at the context of driving without actually doing it. So some of those tools are the Dynavision, a driving simulator where it's available, iPad games, computer games. Note that a simulator, while it does have some limited evidence, it doesn't mean if you don't have a simulator that you can't do off-road training or preparation for driving. Some of the other activities that people use are tabletop activities, board games, letter shape cancellation, physical activities like badminton or scanning while walking, or wayfinding through a clinic, and homework. The quote here is that they or clients have limited visits with me, so learning has to be ongoing and not stop in therapy.
Quick mention, I just wanted to say how with we've noticed in the industry doing driving assessments with people with any sort of disabilities, new drivers, they tend to do so well if they've played sports. Mm-hmm. The athletes tend to do so well, and I don't know what comes first, chicken or the egg. You need to look to the research and see what is supported, but a dynamic, interactive environment, it correlates with good performance on the road.
And so the message here is basically that well, the research shows there's two separate approaches to driving. Clinically, it's a mix. And if you're doing any of these activities, take this as validation for what you're doing. There's no one thing that's right or wrong to do. It's a mix of both component-based activities and context-based activities. Our research is to try and figure out what activity fits to combine all of these things. So we want something that's contextually relevant, trains the visual cognitive skills of driving, is physically interactive, and is feasible in a clinical sense. So we have things like the simulator, which does cover many of those areas, but you can't take a simulator home. You can't work on that in your day-to-day time. Same with virtual reality, at least at this stage. There are other activities like being an active passenger, doing things like lumosity or even tabletop activities, using Dynavision, and all those sort of touch on different aspects of that, but no one thing yet covers all of those areas. So certainly when you're looking at interventions, context matters, training the skills that relate to driving and having some component of physical interactivity, as well as feasibility both in clinic and for a person to take home with them. Those are the considerations you want to make as you're coming up with a program.
To specifically say, active passenger exercises involve the client sitting in the front passenger seat and a family member or friend doing the driving. You allot a specific amount of time to try to, where the client is able to make the decisions for the vehicle, but doesn't actually have control of the vehicle. And obviously the driver wouldn't do anything wrong. But things like, is it safe to lane change? When is it safe to go from the stop sign? That sort of thing.
So in terms of a quick wrap up, let's check back in with Joan. Joan's license was suspended. She had her screening and intervention started at outpatient. She was referred for a comprehensive driving evaluation. She didn't go for it. She decided to retire her driving. So what is this? Is this a success? Is this a failure? She's not driving. The message that we want to leave today is that people like Joan can thrive regardless of their driving status if we address their community mobility early and often. So success, the definition of success does not have to be driving yes or no. Instead, it's choice, control, and access to meaningful roles and activities in the community. In terms of timing, that means addressing driving should be done early and often throughout a person's care, ideally prior to discharge. This comes from the Managing Transitions module from the Stroke Best Practice website, and I put a quote here that I love, which is a call to action for all healthcare professionals for delivering education and support on an ongoing basis, regardless of the patient's location within the healthcare system. We all own this. It's not on any one discipline or any one area to address driving. It's on all of us. Here's, in terms of wrap up, here is all the links that we've provided throughout the presentation. I know, Elizabeth, you said that that the slides wouldn't necessarily be available, but maybe I can send this out as a summary, or you can snapshot this screen to access some of those links. And that's our presentation. We have a few minutes left over here for some questions, comments, feedback.
Ray, thank you very much, Michael and Nellemarie. That was an excellent presentation. And we will send out the resources that you listed in the last slide there. We'll send those along with the survey and recording. So for those participating, you can look for that. So for anyone that wants to send in a question, feel free through the question box, and I will get to a few of them right now because we've had a few come in throughout the presentation. So our first one is for Nellemarie. When a patient has been reported to the MTO and it is now recommended that a ministry approved on-road test be completed, is the patient required to have medical clearance to get the temporary license for the road test? And does that mean that the entire ministry form needs to be completed, and by whom?
So no, when the Ministry of Transportation has recommended a driving assessment, that's basically a functional driving assessment, that's what we do, occupational therapist, 2.5-hour assessment. That means the ministry has decided that they have sufficient information for that person to proceed. So there has been a medical report that they've already received, and they've decided that it's time for them to come for a functional driving assessment. We will then book an appointment with the client and request a temporary driver's license from the ministry, and they will issue that to us in order to be able to conduct the assessment.
Great, thank you very much. Our next question, should everyone who experienced a stroke and did well with the off-road cognition and physical testing still have to do the on-road?
You know what? It's such a tricky question and decision. So what I'm going to bring it back to is, it's this gut feeling. You think that they're okay, but can you make that leap? Make sure you're taking this systematic approach. You know, go through all the boxes, check them all off every step of the way. Is there any impairment at all? Is there any, multiple medical conditions? How many other various reasons to be concerned? Or are there really no reasons at all to be concerned? And that's information you can share with the team and have a conversation around that. But I would say that not necessarily, certainly not everybody has to go for a driving assessment.
No, and then similarly at our facility, I would have that conversation with a physician. If I feel that from my testing that a person's stroke has not affected their ability to drive in any way, and I feel confident in that answer from the work I've done, I'll make that recommendation to the team.
Yeah. It's a hard leap, but like I said, systematic approach, inform your gut, allows you to articulate, and of course, document.
And then certainly if you can document and support it, but the question again that you're answering is, has their stroke potentially affected their ability to drive? If there's any potential that it has, then you should be referring on. Not to save them money, not to protect them from not doing a road test. If there's any potential there, then yes, you should be referring them. If the answer is no, then
it looks good.
Yeah.
Great, thank you. In BC, who can request an enhanced road assessment or functional driver evaluation for a client? Just the doctor? Is the person's license suspended until the assessment is complete?
It sounds like a question with multiple levels to it. Unfortunately, I am not thoroughly versed in the system in British Columbia. I do know that this ERA, enhanced road assessment, it's basically come into play as of March 1st, so I'm not sure how much information there is. I could refer you to, I know somebody who's a resource of mine is, best to call the ICBC. That's when little bird tells me it's best to call the ICBC and get more information, or Google. You could look it up on their website. I'm sure that the information is available. That's all I can say.
Okay, great, thanks. And is there a specific MOCA score or range that indicates risks or concerns?
It's a difficult question, again, because of education, language, everything. But what would you say?
I generally don't use a particular score on a particular test. I combine all my screening tools together to get a picture of somebody's ability to drive. So I mean, someone might do poorly on an individual test, but it might again be maybe they haven't written a test in 40 years and they have low education or low literacy. So again, we're trying to build a picture of whether the stroke's affected their ability to drive, not to use a particular hard cutoff from any one test for that. You're basically painting a picture using many, many different tools and resources.
Okay, great. And what is the best way for clients to follow up when they receive a letter from the MOT stating their license has been revoked and they did not present with deficits impacting their ability to return to driving? Patients are reporting that their family doctors and the neurologists are both unwilling to support return to driving or to respond to these letters. It's very frustrating for patients.
Okay, so basically, when a person's license is suspended, I can speak to MTO, no problem. When a person's license is suspended for medical reasons by the Ministry of Transportation, in that letter, they will get a formal suspension, but they'll also get a letter, and I showed you what one of those letters can look like. It will say explicitly what the person needs to provide in order to be considered for reinstatement. And that may be an up-to-date report from the doctor. They'll usually actually attach the form that they want the client, the driver, to have filled out. Or it'll say a functional driving assessment, or it'll say, you know, that more information about diabetes or whatever it is. And they need to follow those steps. The way I word it to clients is you kind of have to, once you're in the system, you have to jump through the hoops that the MTO puts out for you. So whatever it said in that original letter, and if you don't have the original letter, because goodness knows, knowing my organization, and if some life event turns me upside down, I may not have that letter. You can call the Ministry of Transportation and ask for that letter to be resent. And if you're a healthcare practitioner, you can get front of the line service with that phone number. You just have to follow the menu and press the right buttons, and you will get to front of the line, so you don't have to wait on hold. If the client is with you, they will let you speak with them, ask for that letter to be resent.
I'll jump in as well. As a clinician, if that client gets to you, so as an OT in outpatient rehab or in the community or as a physician, often what I'll do is do that off-road screening, confirm that information and write some sort of letter of support or some sort of letter of advocacy or a report of my findings to a family physician or to a contact for that client to help them navigate that process.
And it's very important to remember, it is not the doctor, it's not the OT or whoever that's taking the license or giving the license. All you're doing is providing the ministry with information in order to make the decision about that license. So even if the doctor filled out the form and said, you know, should never drive again, send it off to the ministry, that might be what the ministry is looking for. It doesn't matter. Just, you know, they just have to do what the ministry has asked for in order to be considered.
So just a follow-up to that. So these are the patients that are just asking for a note from their MD.
Yes. So I sometimes get this question clinically, and my MD or my family doctor might not be willing to address this topic or might not have enough information to address it. So if that client gets to you as the clinician, the way that you can help is through either some sort of screening process or an off-road screening to help support them, or to support the physician having enough information to generate that report that they need to do to go back to the ministry.
And maybe ask the doctor, what is it? Yeah. What information do you need in order to be able to consider doing this? Yeah. And then see if you can provide them with that information.
Okay, great. Thank you. Is there any evidence around the use of off-road vehicles like golf carts, ATVs, etc., or technology for training or assessment for post-stroke clients?
In terms of the best practice and the evidence, I'm not aware of any stand-in vehicles that the evidence suggests that context does matter. So something that relates or feels or looks like driving does have is a better form of treatment because the context is there. But whether that's a golf cart or a scooter in a clinic or a power wheelchair or anything like that, there's no specific evidence linking that to on-road practice that I'm aware of in this moment. But certainly if you have access to that and it's safe, there might be a way to work into context. If you have some power scooters around a clinic, certainly give it a shot.
Okay, great. And I just realized that we've hit 4:01. There are a couple more questions. Are you okay to address those, Michael and Nellemarie?
Sure, yeah.
Yeah, as long as I'm available at 7:30 to watch the Leaf game. Woo! Sorry.
Yeah, for sure.
Go Leafs, go!
Well,
yeah,
I'll just address these last couple, and then we can end the presentation. So, should every patient in acute care go through screening before discharge, considering that they are seen for only a brief period of time?
It's important to address driving. You don't necessarily have the time to screen per se. So bring up the topic, do they have a driver's license? Are they being discharged home to a vehicle? Is there anybody there that can monitor what's going on? I don't know. Is that?
Same answer. So addressing driving doesn't always just mean screening. If you don't have time to go through a battery of screens, certainly a thing that would be very helpful is if you're not going to drive, here's some ways that you can get around, get your groceries, get your medications, and survive in the community in the meantime. Because they absolutely should be told not to drive for at least a month. we can address that by filling in that gap. And that can take one session. That can be a handout that we have ready or something that we can do with the client.
And the follow-up has to happen after months. You can't just go back to it. So, that's when the question should be looked at closer.
Yeah. So screening can then happen. So again, generating referrals either to inpatient rehabilitation, outpatient, in the community, things like that. So address driving, prepare someone for not driving if they're leaving right from acute care, and making the right referrals.
Okay, and do you have any advice on encouraging clients to take a comprehensive driving evaluation if they are hesitant or refusing due to high cost?
That's a big challenge. Absolutely.
It's a challenge.
Yeah. I usually frame it as everything that I do with someone is off the road. It's separate from driving, and going on road and doing an on-road assessment is the best way in terms of the evidence and in terms of context, and the most fair way for someone to know if their stroke has affected their driving. That's sort of how I frame it with clients. There is a cost associated with it. We have to be upfront with that. I give them that cost. Yeah.
See, driving is unfortunately, unfortunately for everybody really, is that driving is a privilege, not a right, and it comes with costs. I don't know anybody who gets funding for their license renewals, for their vehicle repairs, for all of that. And unfortunately, this is one of those costs. It looks like healthcare, it smells like healthcare, but it's not covered under healthcare. So unfortunately, it's just one of the other costs associated with driving.
And just to be mindful of someone, to not prevent someone or to encourage to try and protect someone from having to do an on-road test because of the cost is certainly not the best evidence for that.
It's having an honest conversation with them. I had it last week with a client who we had said, we could do training. Is this something he wants to do? An early diagnosis of dementia? Is it something that's going to be practical? He learned okay in the clinic, followed the directions, no problem. But he's actually got a lot of resources, but he's contemplating not pursuing because really, is that how he wants to spend his money? So it's the same kind of conversation.
And certainly I offer to do as much as I can off the road to prepare someone so that they are as successful as possible when they go to do it. So giving lots and lots of homework, lots of activities they can do to prepare visually, cognitively, physically.
Reach as much, accomplish as much rehab as you can. So don't rush to it. We try to postpone. I don't want to see anybody with any deficits 6 months after their stroke even. Like the longer the better. To be able to make sure that they've recovered as much as they possibly can before they give it a shot and spend that money.
The other piece of that too is if a person is well prepared to not have to drive, then there's certainly a lot less pressure to get back to driving for that person, and there's less of an urgency to it. So if people have good supports and strategies in place, either through their own planning or their own support or through work that we do, then it becomes less of I need to drive now because I have to do that to stay alive or to take care of my family or
get to the mosque daily, whatever
it is.
Exactly.
So if you can help prepare a person, that might be the best way to help them not have to go do an on-road test because they may not need to drive then.
Okay, and our last question, have you done any work to get physicians in Ontario to provide a consistent approach or message to patients regarding returning to driving?
That's an excellent question. I would say that no, aside from just educating as we go, but that does not reach nearly the percentage of physicians that would be necessary. So what is happening though is that with the new regulations that the Ministry of Transportation of Ontario has put out, it gives a physician, and this has been done with a lot of stakeholder meetings between the ministry and physicians organizations, they've made it more specific. So it's not a big, huge gray area. So maybe it is just an emerging trend. Who knows, maybe this will start to spread into other provinces. But in Ontario, at least doctors have a bit more of a concrete plan to follow, a bit more.
Yeah, we're very fortunate to have a great partnership with our physicians at the facility that I work with. And a lot of it comes from back and forth communication. So giving very clear results, recommendations, summaries, and reports so that they're informed, and then we just keep that communication open regarding driving between myself as an OT and the physicians that are working with our clients.
And maybe it is a grassroots approach, right? In each of everybody's own setting, saying to the physicians, how can we support you in this? And, obviously OTs are taking it on now too. So it's about how can we all work as a team and support each other in addressing this issue.
Yeah.
Great. And thanks so much. That concludes our question and answer period and our webinar today. I would like to again thank very much our presenters, Michael and Nellemarie. It was an excellent presentation with a lot of practical information that I'm sure all of the participants will take away and hopefully help them within their work. So thank you to the both of you for all your work. And again, to everyone who participated, please take the time to complete the evaluation. And we look forward to having you join our next presentation in June for Stroke Month. Thanks again and have a great day. And go Leafs go, or go all Toronto too, right? MLS, Raptors, everyone's playing tonight, Jays.
Good luck to the Jets.
Wins all around. Thanks so much and have a great day.
Take care, bye.
Good job, you guys.